Today we have our instruction course. It's a young master instruction course. And it's on the A to Z of flaps and grafts, mainly in oculoplastic surgery, but I've also included ocular surface. So we have a very esteemed set of instructors. So Dr. Samiksha, she works in Solis Eye Hospital in Hyderabad, and she's trained with Dr. Carol Shields and Dr. Santosh Honawar, and she's a prolific presenter and very well known among the young oculoplasty community. We have Dr. Sharon D'Souza, who is a consultant at Narayan Nethralaya, and she's very experienced in lamella surgeries like DSEC, DMEC, and today she's with us for her expertise on grafts for the ocular surface. And of course, we have Dr. A.K. Grover, who obviously needs no introduction. He is a surgeon par excellence, and I have the privilege of learning from him at Vision Eye Center in New Delhi. He is an RPC alumnus, and he's given hundreds, maybe thousands of talks all over the world and authored several papers and chapters. So we are very honored to have him amongst us. So first I'll call upon Dr. Samiksha to come and give her talk on the basics of flaps and grafts. Yours is this, no? Yeah, I'll remove this.
Good morning to everyone present here. I'm thankful to Rwituja and the team to give me this opportunity to speak. I will be starting off this IC with some basics of flaps and grafts. To begin with, I will talk about the relevant anatomy. Externally, the eyelid, the horizontal palpebral fissure is about 27 to 30 millimeters, while the vertical is about 8 to 11 millimeters. The medial canthal angle is about 45 degrees, and the lateral canthal angle is about 60 degrees. The lateral canthus is typically about 1 to 2 millimeters above the medial canthus. When it comes to the cross section of the eyelid, we can notice that it is made up of three main layers that we should be aware of. That is the outer skin, the inner mucous membrane, and a semi-rigid skeleton in between, which is mainly composed of the tarsus in the upper and lower lid. Functionally and anatomically, the eyelid is divided into two lamellae. The anterior lamella comprises of the skin and the orbicularis along with the eyelashes, and the posterior lamella comprises of the mucous, conjunctiva, the tarsus, the retractors, and it is divided from the anterior lamella by the gray line. The muscles that we should be aware of while reconstructing with flaps in this area are the orbicularis oculi, which is a superficial subcutaneous muscle, and the levator palpebrae superioris, which is basically in the form of an aponeurosis that inserts onto the tarsus, mainly in the upper lid. So the skeleton of the eyelid is mainly formed by the tarsus. In the upper lid, it measures about 8 to 10 millimeters and in maximum height, and in the lower lid it's about 3 to 5 millimeters. Both the upper and the lower tarsus gives rise to the upper and lower crura of the medial canthal tendon and the lateral canthal tendon, which go on to insert onto the orbital wall on the medial and lateral side respectively. It is important to know that the blood supply of the eyelid is very extensive, so the grafts and flaps in this area survive very well, and they are quite aesthetic in this area, so it makes reconstruction a little bit easier in this area. It is important to remember these relaxed skin tension lines that were proposed by Arthur Borges. Basically, when we place incisions along these lines, the scar is more aesthetic, more hidden, there's lesser gaping, and better results long term. When it comes to principles, the assessment of the defect is the most important thing that we do initially. We should be knowing whether it is a full thickness or a partial thickness defect, whether it's involving the lid margin or not, the amount of lamellar loss, each lamellar loss, the location, whether it's medial, lateral, or central, whether there is any canthal involvement, whether there is any canthal tendon involvement, whether there is lacrimal drainage system involvement, and age of the patient and laxity of the eyelids is important to decide which kind of reconstruction we want to take up, and including the condition of the opposite eyelid and mobility of surrounding tissues. So when we reconstruct, we have to remember to reconstruct each of these layers that we talked about, that is the skin, the skeleton, and the mucous membrane. Since we functionally divided it into the anterior and posterior lamella, each lamella has to be reconstructed either together or separately. It's important to know that one layer has to carry its own blood supply, so it has to be a flap, and the other can be a free graft. When we reconstruct, we should know that we should maintain a proper lid margin contour. It should conform completely to the curvature of the globe. Incisions and lines should be parallel to, as far as possible, to the relaxed skin tension lines. We should maintain anchorage to the bony orbit in the form of the ligaments that we talked about. The horizontal size of the defect is usually determined by bringing the medial and the lateral edges of the defect a little bit closer under some tension. The LPS and the inferior retractors should be inserted where possible. And lacrimal drainage reconstruction may be either primary or secondary, depending on the defect and the extent of injury. It's very important to know that we should be aiming for symmetry between two eyes. So the options for reconstruction in this area are mainly flaps and grafts. The major difference between flaps and grafts is that flaps are tissues that carry their own blood supply. Grafts are tissues that are severed from their original blood supply. So the flaps rely on growth of new blood vessels also, but they primarily carry their own blood supply. In the area of the ocular region, they give a very good color and texture match. And the facial flaps, usually the main blood supply is from the muscles, so they don't really require to be based on any particular vascular pattern. They may be classified depending on the composition, on the vascular pattern, and their location. So these are some of the types of flaps that can be used in the periocular area. This is an advancement flap where it is detached on three sides from its surrounding tissue and advanced into the defect. VY-plasty is also an example of it. A transposition flap where there's an intervening tissue and the tissue is mobilized, like the upper lid tissue is mobilized into the defect. Or there are sliding flaps where it is detached completely from the surrounding tissue, but it still maintains connection to the underlying muscle, and it's slid into the defect and closed. There are rotation flaps in which the adjacent tissue is rotated into the area of the defect. This is a rhomboid flap which is rotated into the defect, and a bilobe flap. Interpolated flaps also have intervening tissue that is present, and it is used to cover the defect. Island flaps are those which are completely dissociated from the surrounding tissues, and they only maintain blood supply through the underside of the flap. Grafts. Now, grafts are tissues that are mobilized without preservation of original blood supply, so they completely rely on the recipient site vascularity for their survival. The types that are used usually in eyelid reconstruction are skin grafts, and usually full thickness skin grafts, cartilaginous grafts, or mucosal grafts. Sometimes when we're reconstructing an entire lamella, we might require composite grafts. So when it comes to options for reconstruction, the anterior lamella is usually reconstructed with a full thickness skin graft. The kind of areas that give a good color and texture match are post-auricular area, the medial upper arm area, the groin area in children, upper eyelid, or a contralateral eyelid. Flaps that can be used in these areas are Tenzel's flap, cheek rotation flap, glabular flap, trippier, and a Fricker flap. When it comes to the posterior lamella, it mainly is comprised of the tarsus and the mucosa, so it can be reconstructed with the nasal septal mucosa, the palatal graft, the oral or cheek or lip mucosa graft, conjunctival graft, and tarsoconjunctival graft. When it comes to the flaps, the Hughes tarsoconjunctival flap is a very popular method of reconstruction. When it comes to reconstructing both the anterior and posterior lamella, free grafts will not work, as one layer needs to carry its own blood supply. When it comes to flaps, the Cutler-Beer procedure is a very commonly performed procedure, and so is the Mustard lid switch flap. The details of these will be discussed in further talks. So when it comes to small defects, direct closure may be possible in case of young individuals if there's a 25% defect. In case of older individuals, up to 30% defects can be closed directly. It can be helped with a lateral cantholysis or with a semicircular flap. Moderate sized defects will require a lid switch flap or a cutler beard reconstruction. Cutler beard is a basically lower lid, full thickness transposition flap. Large size defects will require a cutler beard reconstruction, or they can anterior and posterior lamellae can be reconstructed separately with the options available. When it comes to the lower lid, usually the anterior and posterior lamella are reconstructed separately with the available options. There are other methods which help mobilize the surrounding tissues and make it easier for closure, because at the end of the day, there shouldn't be any tension at the suture lines. So to summarize, we went through the relevant anatomy of the eyelid, assessment of the defects, principles of reconstruction, and options for reconstruction. At the end of the day, we must remember that treatment has to be individualized to the patient, so the assessment and proper planning is very important. Thank you so much for this opportunity.
Thank you, Dr. Samiksha. And that was really nicely and very simply elucidated. And just a couple of things that I'd like to ask you.
Sure.
You mentioned about repairing lacrimal for the lacrimal reconstruction primarily or secondarily. So how do you decide whether to go ahead in the first when you directly see the patient? Or
So if it is usually due to trauma, finding the lacrimal system itself becomes very difficult, and depending on how soon after trauma they've presented to you, if there's a lot of swelling, it is difficult to find the lacrimal system at all in the first place. But if it is a planned surgery, then it can be done simultaneously.
right. And I'd like to ask Dr. Grover as well. So when you have a tumor, do you prefer measuring the margins in the OPD to decide what kind of surgery you would plan, or do you decide on table?
See, first of all, you have to have a plan in the mind when you see the tumor and you know the extent of dissection that you're going to do, that you have plan A and a plan B in mind. And on the table, you often have to modify it. But you really have to have a plan thought out with your decision having been made to an extent before you start it.
And where do you generally most commonly take skin grafts from, free skin grafts?
So medial upper arm is a very easy place to access, easy to close primarily, and it gives a very good match to the eyelid. So
That's your preferred?
yeah, that's my preferred site.
Okay. Thank you, Dr. Samiksha.
Partial thickness grafts.
Partial-
What about the full thickness ones?
Full thickness ones also I tend to take from the upper lid, and sometimes the post-auricular. I don't like to go for anywhere else. It's just
Yeah, I would like to ask whether you have used any other materials for the posterior lamellar reconstruction.
so I've used amniotic membrane, but I've not gone in for any other alloderm like material. I have not used it. What would you, ma'am, prefer?
Yesterday there was a paper presented that silicone band was used to replace the posterior
For the support, not as a lining.
as a lining.
Silicone as a lining.
It's a lining.
A silicone buckle they had fashioned, cut and fashioned like that and used.
I would assume that if a silicone rubs on the ocular surface, it probably wouldn't be. They may have covered it with conjunctiva, or no?
It was covered with amniotic membrane, yes. Or it was used with the cutler beard thing. So
Okay.
Support along.
Yeah. If you're trying to replace just the tarsus, then I would say that that would make sense.
But it didn't work. I tried long ago. I had many years.
Okay.
But it used silicone.
Okay. Right. Thank you so much, Dr. Samiksha.
Thank you.
I'll be going next, and I will talk about hard palate grafts, and then after that we'll have Dr. Grover with a nice long discussion on upper and lower eyelid reconstruction. audience members up in front so we can discuss easily. Or if you would like to ask any questions. So I'll be talking about hard palate grafting, and it's quite a useful and satisfying procedure, provided it sort of doesn't undergo any major complications. But I find the hard palate graft something which I turn to quite often these days. So the main indication of hard palate grafting is for lower eyelid retraction, for entropion, where the middle lamina or the posterior lamina has shrunk. So there can be inflammatory eyelid retraction because of trauma, a previous failed surgery, or conjunctival scarring, or secondary to thyroid eye disease, or even after a lower lid blepharoplasty. It's also used in socket reconstruction, wherein you need to create more of a surface in the socket. So the options generally for posterior lamellar replacement or augmentation are scleral grafts, ear cartilage, auricular cartilage, alloplastic materials like alloderm, which Dr. Samiksha was talking about, nasal mucocartilage, tarsoconjunctival flaps or grafts, and the hard palate grafts. So what are the benefits of a hard palate graft? It provides a good mucosal lining and as well as some amount of rigidity, which you don't get in a mucous membrane graft alone. It is abundant, so you can take a nice large graft from the hard palate. It's relatively easy to harvest, and it's an easy harvesting skill to pass on as well to trainees. It is autologous, it takes up fairly well. It doesn't shrink all that much, as much as a mucous membrane, and it doesn't have a large complication profile. So first thing is to assess for how much posterior lamellar shortening is there. So you do the stretch test, and to differentiate from cicatricial ectropion. So you have to look at the anterior lamella as well and check how much of lid laxity is there to see if you have to plan any other combined procedures. So coming to the surgical technique, you go towards the outer part of the second molar, and basic thing is these measurements are not hard and fast. They are basically that you have to be a little bit away from the midline and away from the rugae. So the main thing is not to take the rugae into the incision. So to exclude the rugae so that you have a nice smooth graft. So the first thing we do is we inject lignocaine with epinephrine into the area of the donor site, and we incise posteriorly and anteriorly till the rugae. So the incision will be a little bit lateral to the midline. So this here you can see the mouth is being opened with a Boyle-Davis mouth gag, and definitely this surgery has to be done under general anesthesia. Once you excise the graft, so the graft is basically, it contains the hard palate, not the bone part of it, just the mucosa part. And underneath that, there is a fat layer. So the fat layer has to be removed. So here in this part of the graft, you can see the lobules of fat which are attached to the graft. This has to be excised and cleaned before you go ahead and put it in your recipient site. So in the host bed, the main thing is to clear the lower lid retractors. So you have a nice incision in the lower lid, and I'll be discussing the surgery in detail. So once you put a nice local anesthesia with 1 in 80,000 adrenaline, preferably, you go ahead and put a traction suture at the limbus, mark the incision about 3 to 4 mm below the tarsus. This is the usual site of incision in the transconjunctival approaches. This is done with a monopolar cautery preferably, so as to reduce bleeding as far as possible. Then with a periosteal elevator or any other blunt dissector, the dissection is carried out, and eventually you release the lower lid retractors. Then this is the demonstration of the cleaning of the graft. So all those excess fat globules are removed, the graft is trimmed, and it is measured. So it's best to oversize the graft a little bit. One second, I'll just start it again. Yeah, so it's best to oversize the graft and to account for the amount of minimal retraction that occurs in the graft. So it's best to bring the eyelid a little above the position that you would actually desire. Then it is sutured in an interrupted fashion, suturing the ends so that you have the primary sutures in place. And then you can put a combination of interrupted and continuous sutures. So this is done with a 6-0 vicryl suture. And in this case, we are only doing the heart palate graft. So there is no lateral canthal procedure or lid tightening. And then you can go ahead and suture the rest of the graft. So after the surgery, at the end of the surgery, this is how it looks. So that's the graft in place. And that helps, once you've released the lower lid retractors, you put the graft in place, you'll see that the eyelid has come up nicely. It's important to put the patient on a steroid antibiotic topical combination after surgery. And ideally, the lower lid traction sutures that you see here that were used for the surgery, it's best to pull them up and suture them towards the forehead, just like how you would do for a frost, to keep the traction for as long as possible. So you need not remove the patch on day 1. You can probably wait for 48 to 72 hours before you remove the patch. Some of the complications that could occur are the early ones, such as bleeding, infection. Hematoma of the palate is not something I've seen, but bleeding is something which is very common. So when you're in the OT, after you've completed a hard palate graft, the anesthetist never lets you leave the OT until you've controlled the bleeding of the hard palate, and it can bleed for hours on end. So it's important to place a pack which has adrenaline in it in the hard palate at the end of the surgery so that you can resolve the bleeding as soon as possible. Graft necrosis is something which can rarely happen. Suture dehiscence, erosion, if it is not operated properly. However, if I would say I would ask our audience also and our co-instructors if they prefer a combination of interrupted or interrupted and continuous, or what they would like to do. And there can be over-under correction. However, the undercorrection is something which you notice much later on. It's not something which you would see on day 1 or even the first month. If the graft has to contract, it will happen probably 3-4 months down the line. Thickening of the lower lid, as you see in this patient, sometimes because of multiple surgeries or excessive scar formation, but there are treatments for this. So this is a patient, she's a young girl, and her main issue was with the left eye lower lid retraction. Now she developed this because she underwent a squint surgery for the inferior rectus in the left eye, and after this she presented to us with a lower lid retraction. She had also undergone ptosis surgery elsewhere for the left eye upper lid, but she wasn't as concerned about the upper lid. Now she wanted to get engaged. So she said, just give me a temporary procedure. So we did a lower lid filler for her with a lift. But then after the filler, she felt that no, her photographs still didn't look good enough. So then she opted for a hard palate surgery. So after surgery, it had corrected well, and she was doing well after surgery. So then we've planned a ptosis procedure for her. This is another patient who underwent anterior lamellar reconstruction about 4-5 years earlier. And after that, she was concerned about her lower lid. So once we had done her lower lid hard palate graft, that is at 4 weeks, the appearance after surgery. But she had that thickening and bit of scarring that remained in the anterior lamella, which sort of prevented her eyelid from going up as far as we would have wanted. So we injected 5-fluorouracil, which is one of our go-to drugs for treating any kind of post-operative scarring, or initially it was thought that it's only useful at 4 to 8 weeks after surgery, but now we found that even 6 months, 1 year after surgery, 5-fluorouracil helps, because there is a lot of remodeling which goes on even after 8 to 12 months. So this patient did well cosmetically after the 5-fluorouracil injections, which were given 4 weeks apart. This is a patient who had lower lid retraction because of thyroid eye disease, and we did a hard palate graft for him. Again, he was overcorrected, and he did well after surgery. In this patient, he came to us first for orbital decompression. So he underwent orbital decompression on the right side, and he did well for the enophthalmos, but the lower lid retraction persisted. So what we wanted to achieve in the OPD, we decided that we'll pull up his eyelid. He didn't have any anterior lamellar issues, so we just had to put the posterior lamella together. And this is him with his graft. And on day 1, he was nicely overcorrected. And this is the amount of overcorrection we would like by 1 week, so that later on, the symmetry is good. So I would say the hard palate grafting is a nice tool for an oculoplastic surgeon to have, especially for lower lid malpositions. And thank you for your patient listening.
Very nice. Would you use it for the upper lid?
Yeah, it's a good thing for the upper lid as well, but it's not very, I've not used it before for the upper lid, but because of its basic structural integrity is good, but I don't know how heavy it would be for the upper lid.
Or how heavy for the cornea?
Yeah.
Maybe we should try.
Yeah.
Not yet tried.
Yeah, we haven't.
Nice to have Dr. Prasad.
Yeah, I was really surprised when he walked in and he looked at the monitor and he still decided to come and sit, and I was like, oh my God, like really honored by that.
Is there a hard way of doing it? Any easier alternatives than going to the palate and taking it? Or what is special about the hard palate?
Yeah, so the hard palate, other options are like mucous membrane grafts. But what happens with a mucous membrane graft is the contraction. Dr. Shalu is also here. Thank you. So what happens with the mucous membrane graft is again the contraction. Hard palate has a good structural integrity, which you don't really get with mucous membrane grafts. Other options are scleral grafts. Yeah. So scleral grafts are again a good thing, but you know that mucosal surface that you would like to have, it's good to have some conjunctiva to cover. So if you don't have that either, then you go for a hard palate graft. I think Dr. Shalu has already seen my talk, so we can discuss with her as well about hard palate. Samiksha, you had a question, yeah?
What kind of post-op precautions do you recommend?
Yeah, so
The oral area and
yeah, so the oral area, actually pre-op, we ask, this I forgot to mention, so pre-operatively we ask them to be on betadine gargles for 3 days, and then post-operatively as well. So the betadine is not just like a good antiseptic, it's also something which gives you a bit of chemical cautery for the hemostasis. So betadine gargles. The second thing would be, like I mentioned, the traction sutures. So the traction suture is really important. Even after 3 days, if you don't want to release the traction, you can still put the traction and, after removing the patch, keep them on traction for at least a week. that really helps.
And post-op instructions like that after dental extraction, those are the things taken with a ice cream, taken with a
Straw.
No salt.
no salt.
Huh, correct. No salt.
Rub salt on the wound.
Yeah.
So we can have Sharon next, and then
Sharon is in another IC. She's in Hall C, I think, right now. So she asked to go last. So we'll have yours. So next we have Dr. A.K. Grover, who has years and years and years of experience in lower lid reconstruction. And I'm sure everyone will be enthralled by the sheer number of cases and experience that he has to share with us.
lower and upper.
Upper and lower, everything.
I thought I could adjust it to the time that was left after Sharon spoke.
Acha. No, it's okay. Even if she takes extra 5 minutes, it's fine.
So thank you. Samiksha made things much easier for me, having outlined all the principles of evaluation, the flaps, and also the choice of procedures was very well outlined. So as we know, we deal with either congenital or eyelid defects. We'll be dealing with indications, principles, which have been elaborated by Samiksha. Evaluation has been already elaborated. And then the management of each of these defects, non-marginal, full thickness, involving margin, flaps and plasty, and canthus reconstruction. Most of these have been dealt with in principle. So various types of colobomas, upper lid and lower lid, those associated with partial cryptophthalmos with exposure keratopathy where skin runs on to the cornea, we all need to deal with them, and the commonest are surgical resection of eyelid tumors. She's already spoken about the lamellae that we need to reconstruct, anterior and posterior, but posterior with the requisite support. And as she said, you need intact vascular supply in one. Evaluation is important to decision making, which she has dealt with very well. So let's deal with the different kinds of defects. Non-marginal, generally taken as an ellipse and along the tension lines that she spoke about. And you must not leave any tension on the wound when you close. In the upper lid, the principle is to be parallel to the eyelid margin, which is along the fibers of orbicularis and along the lines of tension. In the lower lid, you sometimes have to make this vertical in order to make sure that you do not pull on the margin and cause an ectropion. So this would be removed as a vertical spindle and closed as such. But you do not want to leave any tension, so you may need flaps or grafts, like for this kissing nevus, where we have used a full thickness graft and a advancement flap for a defect in the lower lid. For the full thickness defects, she spoke about the direct layered closure. In the older subjects, you can go up to 40% with lateral canthotomy and cantholysis. Like in this case, where a pentagonal excision with a 4 mm margin has been done for a localized BCC and closed directly. For those up to 2/3, she's already spoken about her choices. The Tenzel's flap, which is mobilization from the lateral canthal region. The skin flaps either from the upper lid or from the forehead region. The Trippier and the Fricks flap. She's also spoken about the tarsoconjunctival flaps, which is the my go-to technique for posterior lamellar reconstruction at canthi, lower lid, upper lid. This is a beautiful technique. Does very well for defects up to almost up to 2/3. Only for larger ones do I need a additional graft with support. So then I would think of a tarsoconjunctival graft or a nasal mucocartilaginous graft or the hard palate graft. And of course, mustard is flaps. So we will look at this video just to highlight some of the principles of reconstruction. So first, the defect has to be converted into a pentagonal shape where the pentagon goes vertically till the edge of the tarsal plate. The two are parallel to each other and perpendicular to the margin, and then you convert it into a pentagon. Then you create this semicircular flap for the upper lid with a downward curve, for the lower lid with an upward curve extending up to the orbital margin generally, not beyond. Then it is important to free this area fully with a canthotomy and cantholysis and do a good undermining of the skin. So this is the canthotomy was already done. So this is a cantholysis, and then you need to do a good marginal repair once the tension is gone. So 3 millimeter vertical mattress sutures, 3 millimeter and 1 millimeter coming back on the same side with 3 sutures at just behind gray line, anterior and posterior. Tarsal repair, skin repair, tarsal with a partial thickness vicryl suture, reconstructing the angle with a retained acute angulation, as Samiksha said, is important. And then mobilization to close the skin, and finally a suture to form the fornix, because conjunctiva also becomes shallow there. So I'll summarize and hope that Sharon can spend some time on the rest of the things. So I'll just briefly go over so this was an example of Tenzel's repair with a canthal malposition, repaired and good reconstruction. Trippier flap you take from the upper lid skin like this, and the Freak's flap is like forehead region. So we'll see an example where there is a basal cell carcinoma here. We've used a tarsoconjunctival flap for the inner lamina and a Trippier flap for the skin. And this is how it looks at the end. And then once we open it up, we can get a fairly good reconstruction. Lid sharing procedures, tarsoconjunctival flap, the most important to be avoided in young infants. And example of a tarsoconjunctival flap used here for the upper lid defect. I'll skip this video, and this is how well it can be reconstructed for a huge defect like this as well. And an example of a lower lid defect where again a tarsoconjunctival flap has been used, tarsoconjunctival and medial canthus with a Trippier flap. And Cutler beard, of course, need not be elaborated, where we mobilize both the laminae, leaving just that 4 millimeters to retain the marginal blood plexus supply, and use the anterior and posterior flaps both. Open it up at 6 weeks. Most important thing in second stage to make sure you leave enough mucosa to form the margin, and can be used in various cases. Inverse Cutler beard with the same principles, but with a little extra caution that you don't compromise the upper lid. Mustardes, pedicle flap, full thickness margin, including cilia, can be transposed. And for the larger ones, you need the midline flap, either the glabular flap or the midline flap, or but you need to also have the posterior support in these major reconstructions. So let's look at some of the example. A tarsoconjunctival taken from the other opposite upper lid, leaving behind marginal 4 millimeters. So you can get a significant thickness of 4 to 5 millimeter width. Nasal mucocartilage. Mustardes cheek flap is no longer very popular because of the large scar that you leave behind and large things that you do. Sebaceous carcinoma. This is a superficial temporal artery based flap. So another example of a superficial temporal artery based flap along with the tarsoconjunctival flap where you can do a reconstruction. This was a lady who refused surgery for several years rich lady, but then when advised, biologics thought that surgery at 1.5 lakhs is cheaper than 10 lakhs for biologics. So underwent a huge reconstruction, which was non-operable, I would say, but we did carry out a midline forehead flap. We thought we must cover the eye somehow. Nasal mucocartilage graft taken, free skin graft also taken in this part. And finally, we had something like this at 4 weeks and something like this at 3 months. She doesn't want any further improvements, which we have suggested. Lateral canthal defects. What is important is lateral attachment to the periorbita and periosteum with double arm sutures. So we either do just the double arm sutures with proline, or you may need a periosteal flap. Or so examples are of reconstruction of lateral canthus. Again, what is most important is that fixicity with the periosteum at the right position, and making sure here again we are using a tarsoconjunctival graft, but making sure this is attached well at the lateral canthus and to create that right angulation for the lateral canthus at the end of the procedure. Medial canthus, important to anchor behind the periosteum here. This is the important part of it. So this is how it is done. Sometimes you need these low profile mini plates for that purpose, so that you can get a good reconstruction. So eyelid repair reconstruction is based on the properties of the eyelid defect. Simple closure, flaps, grafts need both lamini, and precise reconstruction of canthi is critical. Thank you very much, and let's hope Sharon can spend some time.
Thank you so much, and I'm sure everybody enjoyed seeing all the various examples that he's operated on, and literally everything in the textbook, so nothing more to cover in this. I invite Dr. Sharon to give her talk on mucous membrane grafts for the ocular surface. So this is something which the oculoplastic surgeons are very interested in, but I think the cornea people are a little more concerned about the ocular surface than us, so she'd be the best person to tell us. She's a very well-known ocular surface specialist, and she's one of my teachers. So the day I saw her do a mucous membrane graft, I decided that someday I will invite her if I ever get the chance to present an IC. So really honored to have you, ma'am.
Right. Good morning, everyone. It's an absolute honor to be part of an IC with Dr. Grover. Thank you so much, Rwituja. It's a pleasure joining this IC with all of you. So without further ado, I'll be talking about one of the surgeries which is really one of my favorites, because it really makes a life change for these patients. Many of them have been struggling with daily issues due to their chronic sequelae on their surface. So we'll just get into it. So before we go into what is abnormal and why we need to do this, it'll be a slight thing, but I'll rush through it. It's very important that we understand what is the normal ocular surface. So everything from the direction of the eyelashes, as Sir was so beautifully showing in his videos, we are trying to reconstruct what is our natural anatomic directions, because that is what keeps the eye safe. So everything from that to the luster of the cornea to the approximation of the eyelids to the bulbar surface is extremely important. And unless we are able to identify or understand this, the subtle changes in the ocular surface become more difficult. So when we evert the lid, we need to understand a few things about the normal lid anatomy. So one is the eyelashes and the lash line and how they are directed and how they are placed, the junction of the epidermis and the conjunctival surface, how the meibomian gland orifices appear, the mucocutaneous junction, which is a very, very important landmark, and very often this is distorted, and that's what we'll be seeing. The subtarsal fold, again, a very important anatomical landmark for us, and then the tarsal surface, which in chronic cicatrizing conditions could have some amount of scarring, which we see as white feathery bands, or worse, as fibers and fronds there. So once there is a distortion of the mucocutaneous junction, we remember that it was on the lid margin in the normal condition, but even in a subtle case, it can progress and change its position and go posteriorly onto the tarsal surface, and that is what we're looking. This, of course, is a very gross case where the keratinization is so visible, but sometimes there'll be very subtle changes, and we need to really look. And a staining at this point, just the fluorescein stain, would highlight this area with a negative stain. So it's very easy to pick up, but always look for it. When would we need to intervene for a mucocutaneous junction lid abnormality? So, or rather, which is the ideal case for doing a lid margin mucous membrane graft. So, of course, we do need an abnormality of the mucocutaneous junction with the lid margin keratinization. It has to be associated with what we call lid-related keratopathy, which basically means we can attribute the changes on the cornea to the lid margin changes. Okay? In these conditions, especially in chronic Stevens-Johnson syndrome, these patients could have keratopathy due to various other conditions, including a very severe dry eye that they have. So we have to be sure that, because if the keratopathy is due to their dry eye, then doing a mucous membrane graft would not help them as much as we would like. Also, you want a slightly wet eye to have an ideal outcome. You do not want a bone dry surface. These grafts would not do well. Of course, it does not mean you can't do, but really we wouldn't be benefiting as much. There we would use other modalities of help, including a scleral lens. Of course, very, very important to differentiate what we think to be keratinization from meibomian gland atrophy, which appear as small little whitish changes where you expect the meibomian gland to be, and they are subconjunctival, they are not keratinization. Again, those are not ideal for a mucous membrane graft. So the perioperative and preoperative considerations that we have to keep in mind, of course, the diagnosis. A lot of things can have chronic cicatrizing changes on the surface. All of them are not SJS. Of course, the history is very important in these cases. SJS is such a bad allergic change that no matter how long ago it was, unless they were really very small children, the patient would remember an admission to the hospital because they are like it was having burns. But you can ask leading questions about changes to the hair, nails, oral mucosa, blisters around the mouth. They very often don't remember the inciting medication. But get the diagnosis correct, because if it is something like pemphigoid, again, we would burn our fingers if you're trying to do a mucous membrane graft there. Differential fluorescein staining is what I was trying to say. If you do the fluorescein stain and you see the staining at the upper and lower limbus, the punctate confluent punctate erosions there, which is where the lids abut the cornea, then you're quite sure that that is secondary to the mechanical trauma, microtrauma, which is happening by the lids rubbing on the cornea. Whereas if you're seeing a very diffuse staining, it could also be, in addition, also have some amount of dry eye, and that is attributing to it. So look for a specific lid-related keratopathy. In addition, if it's a very chronic change, you can have other changes like opacification, vascularization in those regions, and that would also be, an indicator. What is the ideal source of the mucosal graft? So, of course, we need something which has a non-stratified, non-keratinized epithelium, because those are rough and not rough. So the easiest place that we have access to is the oral mucosa, and usually we take the labial mucosa. In that also, the lower lip gives us the best and largest access, so that's our first choice. But we can always take from the upper lip or the buccal region or even the soft palate. Hard palate is avoided. Prophylactic antiseptic mouthwash for a few days would help. It's always a good, even though we don't really, we're not bothered if they don't have very good dentition, but they should not have any caries or cavities, because that would, of course, then infect your graft. But unlike an osteodontokeratoprosthesis, where we are fanatical that they should have very good teeth, here it's not really that important. Coming to the anesthesia which is required. So you can do it either under general anesthesia or a local anesthesia. In case the patient is not fit for local, I do most of mine under local anesthesia because my anesthetist is a little hesitant to give GA to these patients. But just a few things. It's much easier under GA for both the patient and the surgeon. It becomes very comfortable. But it can be done under LA. Few things to keep in mind. You need to pack the mouth. So you have to have 3 strategic packs on both sides, the buccal and under the tongue. Inform the patient that he may have some fluid, but you have to be quite diligent about doing the suction when you're harvesting the mucosa, and of course count your packs and remove them. If you're doing under GA, you have to instruct the anesthetist to pack around the ET tube so that there is no fluid or blood which tracks down and makes the patient aspirate. Otherwise, it remains the same. For perioperative vasoconstriction, even if you're doing it under general anesthesia, you would infiltrate with glucane with adrenaline to reduce the bleeding in this area. So why are we so fanatical about doing this procedure? Just to highlight with this case, this was a young girl who had Stevens-Johnson syndrome and then presented with the chronic sequelae. And you can see the very obvious keratinization which is present on this lid margin, both on the upper and lower lids. And obviously, this is going to cause a lot of keratopathy, and this is her cornea, which shows so much of opacification. There's also vascularization. And obviously, in addition to this, it's very painful and irritating for her to even open the eye. So we went ahead and did the mucous membrane graft. And after the mucous membrane graft, you can see a lid margin, which is much more uniform. Here you can see the healthy MMG, which is well approximated to the lid margin. And what is most striking is just by doing the mucous membrane graft, we have done no procedure on the cornea, but just by removing the inciting agent of that mechanical microtrauma, this is how the cornea clears up. And it will clear more over time if we put in a scleral lens or this thing. But now, this is vision that that child can work with, go to school with, etc. So very briefly, I'll go over the steps of surgery, depending on how much time I have. So the first thing that we do is, of course, we put a lid stitch and evert the sutures. The measurement is important. Usually we take about 20 millimeters. Even if the keratinization is over a small area of the lid, is visible, do not make the mistake of doing a very small MMG. Do it across the lid margin, because it will otherwise come back in the region where you've not done the MMG. So that marking is important, irrespective. Try to avoid including the puncta in this. Very often the lid margin anatomy is totally distorted, so you cannot look for your landmark of the mucocutaneous junction or the meibomian glands. So you can then, in that case, take your incision just posterior to the lash line. Make an incision with the Bart Parker knife, and then you go horizontally, because the direction is you want to go over in front of the tarsal plate. You do not want to cut into the tarsal plate, because then you can have further complications, and we'll show you how the tarsal plate is exposed in that case. And once the suction is always constant. Now you realize that there's not so much of bleeding visible here in this, and that's because we are putting tamponade from under the eyelid, and here it's put with 3 buds, but sometimes there are certain clamps which are available to us, which can also help with the tamponade, which is very important. At some point I will release the tamponade and you'll see how the blood comes in. Using alpha-gun Z, brimonidine, is also a very useful thing for most ocular surface procedures. It really helps to reduce the amount of bleeding. So here, I don't know if it's visible. So here, this region which is exposed is just in front of the tarsal plate. Make sure that you're going in above it and not into it. So that plane of dissection is very, very important, and you have to dissect at least around 5 millimeters so that you get a good exposure. Yes, we're done. Okay, so once we've taken the graft, it is important to thin out the graft so that we wrap around the tip of our finger and thin out. You do not want a very bulky MMG, because then again the patient will have more irritation. And we suture it to the eyelid margin using 80 Vicryl with mattress sutures. It has to lie flat, and the posterior surface we glue with the fibrin glue. So you can see that it would be well posed against it. I'll just run this. Right. Posteriorly, I don't put sutures, only anteriorly, but you can suture all around. I know a lot of surgeons who suture all around, so absolutely not a problem. Just make sure you don't have any suture ends on the tarsal surface. Bring it all onto the lid margin. So they have a very good eye opening immediately after. Again, just to show that in case you do not have the lower lip, you can take a graft from the upper lip as well, but you just have to make sure that you do not damage the philtrum or any other structure. So there can be certain complications. This is a very good article written by Swapna Shanbag and the group from LVP for anyone interested in starting off mucous membrane grafts. So good to know if there are some minor complications, how to handle it. And with that, thank you for your patient listening.
Thank you, Dr. Sharon. That was a wonderful exposition of that surgery. And it's not very easy. It has to be done with that meticulousness to get those beautiful results she showed. Thank you for a wonderful session. Thank you, Samiksha. Thank you, Sharon. Thank you, Rwituja. And thank you all the wonderful audience, including KP and Shalu, for being participants in this wonderful discussion. Thank you so much. Yeah, let's have a picture. Without the chief instructor.